So my topic is when PrEP fails. So really it's an update of where we are with treatment. But of course, as Anton has very eloquently demonstrated, PrEP does work. We know that PrEP works, but for PrEP to work, of course, people at risk have to take it. They have to take it in the right way. And crucially, of course, and the thing that's affecting many of us in Europe and definitely in the UK, is it being available. And by being available, there's a whole issue of it being commissioned by your healthcare services or licensed. That ties in with how affordable it is, but of course it has to be supported, and that's support in terms of education and awareness, but also support in terms of administering the drug, monitoring the drug, as we've just heard now. But of course, at the moment, and certainly Anton's talk's very global, mine's going to be more focused on Europe and particularly the UK because of some of the UK data I have. But we know that right now, although it's going up, European PrEP coverage ranges from non-existent to low. And we don't yet know actually how feasible really wide-scale rollout is going to be, because in order to impact the epidemic, we're going to have quite wide access of PrEP required, and are we going to be able to achieve that? And as we've already alluded to in terms of the PK discussion, we still don't know if intermittent PrEP is going to work. So yes, intermittent PrEP might work if you take it regularly, but will truly intermittent PrEP be effective? Now, ultimately, of course, we're all taught that prevention is better than cure, but unfortunately, in the case of HIV, we have too little of one, and actually right now, none of the other. So we do have to focus on managing the fact that we have high rates of people acquiring HIV, and of course, very high numbers of people living with HIV. So just a very brief reminder of epidemiology in Europe right now. These are the figures in blue for the EU and the European Economic Area, and green including the WHO European region, excluding Russia. And what you see is round about 2014, 550,000 people in the EU, and in total about 950,000 people in the WHO European region living with HIV. But if you look at the number of new diagnoses made in 2014 in that region, it was 142,000, and that's the highest since reporting started in the 80s. So as Anton's already told us, of course, we need new technologies and new methods to address this. Now, this is our data from the UK, and it's the blue line that's concerning. This is the rate of new diagnoses annually in men who have sex with men, and like many European countries, that is going up year on year. And so 2014, again, the highest number of new infections in MSM in the UK since reporting started. So I'm going to go through the issues of diagnosis and treatment. So we know that an unacceptable proportion of HIV remains undiagnosed, and this is the global estimate. More than half of HIV globally is thought to be undiagnosed. It's quite difficult to get recent country-level data in Europe, and this is some data from a Cascade paper that actually Anton was an author on that was presented last year. And this shows, if you look, for example, you have rates as high as almost 50% undiagnosed in Georgia, down to 15% in Denmark, but you can see around about 20 to 25% here being undiagnosed. This is our UK data by different risk groups, blue for diagnosed, red for undiagnosed, but to summarise that, at home, it's estimated it's 18% of people with HIV are undiagnosed, and if you break that down as consistent with many European countries, that is more common in heterosexuals. And in the UK, it's particularly heterosexuals who are not black African. We have national testing guidelines for men who have sex with men, and we have national testing guidelines for black African individuals, but certainly non-black African heterosexuals, you're seeing round about 1 in 3 are undiagnosed. And actually, a lot of discussion is made of how much improvement we've made in terms of undiagnosed HIV, that the proportion of people with undiagnosed HIV in the UK has gone down. But actually, the numbers are relatively static. And of course, the proportion who's undiagnosed will go down as the people living with the condition increase. And as people are aging and living longer, we can get false reassurance from those figures. So looking at the numbers who are undiagnosed is, of course, important as well. Now, you'll all be very familiar with the many implications of undiagnosed HIV. To break it down into 3 broad categories, there are, of course, the individual implications, in that an individual who's undiagnosed may present late, and we'll touch a little on that in the next few slides. They may get sick, and, of course, there's a higher risk of death. On a kind of society level, there's the risk of onward transmission, and we know being undiagnosed in itself is a risk factor for onward transmission, and of course the society costs of managing the medical costs of advanced disease. And finally, in terms of prevention, really prevention has to go hand in hand with testing, of course. And if you're not testing someone HIV negative, you're not having the opportunity to talk to them about HIV prevention strategies. And that leads me on to late diagnosis. So I'm sure you'll be very familiar with this definition that was published in 2010. Now, the definition of late diagnosis has evolved as our treatment guidelines have evolved. So it used to be below CD4 below 200. It's moved up. But certainly anyone presenting with a CD4 count less than 350 is considered a late presenter. And actually across Europe, almost 50% of people are diagnosed late based on a combined CD4 and clinical definition. Now, we're seeing declining numbers of AIDS cases or AIDS diagnoses across Europe, but actually 2 in 3 of them are in newly or recently diagnosed people, so people who have presented when they're clinically unwell. We know that what drives the other third is mainly people who've been disengaged from care, people who've been diagnosed, not engaged in care, and then re-presented later on with an HIV-related illness. Now, I've put this report in. I'm very aware it's UK, but this is well worth reading. It was published last year, and it's an evidence review, but it includes data from outside the UK as well. So for an up-to-date, short, easy-to-read review of late diagnosis, actually, I would recommend this. Now, again, this is our UK data, and in the UK, we see that about 1 in 3 men who have sex with men, but more than half of heterosexuals are diagnosed late based on that CD4 definition. But there is a suggestion this is going down over time, and I think the data is similar in other European countries, but it's not really going down as much as we would hope from our enhanced testing efforts. Now, again, this is all fairly obvious, and you'll all be very familiar with these issues, but the issues associated with late presentation, of course, include transmission. The longer someone remains undiagnosed, the longer that period of time they may be transmitting to others. Healthcare costs, I've mentioned. Increased mortality, we know, is a big issue, and certainly UK data shows the mortality is increased tenfold in the first year after diagnosis if someone presents late as compared to somebody who doesn't, so an almost 4% mortality rate compared to 0.3. There's the impact of an AIDS diagnosis on mortality. So someone who's been diagnosed with an AIDS condition does have an elevated risk of mortality, maybe for several years afterwards, and that varies according to the diagnosis. And of course, long-term comorbidities. We know that a previous history of severe respiratory infection, PCP, is associated with a higher risk of chronic lung disease in the long term. And of course, when we look at the frequency of comorbidities in people with HIV, for many, a risk factor appears to be a legacy of profound or prolonged immune suppression, a legacy of prolonged periods of viremia. And these are all enhancing the risk of some of the age-related comorbidities that we're managing in clinic. Now, what are the risk factors? They've been looked at in many cohorts, and broadly speaking, people at greater risk if they're older, if they're heterosexual as compared to men who have sex with men, non-national, and certainly people who live in countries where they're not entitled to health care, there's a very high risk of late diagnosis. And generally speaking, men, although that's partly driven by the fact that women who bear children are offered testing antenatally. In terms of the reasons, why do people not diagnose until they're unwell? I mean, many people just haven't tested before, and if you look across Europe, late presenters between 32 and 55%, that's their first ever HIV test. A lot of that is driven by risk perception. People do not perceive themselves to be at risk, they do not perceive their behaviour to be a risk. And people may feel well. When you feel well, you don't think about your health, and you don't necessarily think about testing for health conditions. Of course, stigma, fear about diagnosis, fear about the implications of diagnosis, and again, especially tying in with migration issues, and lack of access to testing, the fact that it's not as broadly available as it should be. And finally, lack of offer. Lack of offer from healthcare providers is a significant reason. I just want to touch very briefly on risk perception, actually bringing it back to PrEP. Now, we know if you look at people who are diagnosed with HIV late and you ask them about testing, they have not perceived themselves at risk, even if they would fall into a high-risk category. And this is one of the concerns about PrEP, I think, and I've put this in because it's more recent. This is data from IAS. And this was a validated risk assessment tool. It was a study performed in Toronto, and what they showed is almost 70% of those men who were objectively at high risk did not perceive themselves to be. And clearly for PrEP to work, people who are at risk need to take it. But in order to take it or even ask about taking it, you must perceive yourself as being at risk. Going back to the reasons for delayed testing, lack of offer, of course, is a thing that's completely unacceptable. That's one thing we can do. We can't address stigma overnight, but we could certainly make sure that our healthcare services are at least improving their HIV testing rates. And here, of course, we have the European HIV testing guidelines published in 2014. Many countries have individual level guidelines, and of course there's global guidelines as well. But broadly speaking, recommendations for HIV testing are broken down into people who fall into at-risk groups, people who attend higher risk clinical services, people, of course, with conditions suggestive of HIV, and finally, services or fields where routine testing should be offered. And they're broken down there with some examples. I think we're all familiar with the groups that are at higher risk and the services, and certainly sexual health services, viral hepatitis services. Of course, anyone with an AIDS-defining illness, but I do think we're improving the message about non-AIDS-defining indicator conditions, which are suggestive of a higher risk of HIV. Those are the conditions, of course, that we'll be presenting to primary care physicians and our general medical colleagues. So it's about making sure that people who are not in the HIV or sexual health specialty are aware of those indicator conditions. And certainly, again, routine testing is going to vary, because clearly what's going to limit anything, and certainly with PrEP as well, is cost and cost effectiveness. And certainly at home for us, if the background prevalence is greater than 2 in 1,000, which is essentially the whole of London and some of the other major cities in the UK, then we should, and I say should because we're certainly not, but we should be offering testing to all acute medical admissions and all primary care registrations. In terms of indicator conditions, this was put together by the HIV Europe group, and they list a variety of non-HIV related indicator conditions that should prompt a test. That is evidence-based. There was a large study called HIDES, which looked in clinics, looked at people presenting with a number of indicator conditions. I won't go through them all in detail, but the majority of the conditions listed there, including viral hepatitis, infectious mononucleosis presentations, and other conditions, all had a prevalence more than high enough to justify routine testing. And for all of them, even the lower limit of the 95% confidence intervals, even the lowest estimate of prevalence, was high enough to justify routine testing. And in terms of overcoming barriers, again, the barriers to testing is a whole other talk, and they're listed here. They're all fairly obvious. I'm not saying any of them are easy to overcome, but these are summarised very well in the ECDC guidance about how to increase uptake. Now, clearly that's going to vary from country to country, from region to region, and even clinic to clinic, but that's a very helpful document to help guide your discussions in improving HIV testing in your areas. So from testing to treatment, this, I think, summarises the benefits of treatment. I think we really are all pretty agreed on these now. For an individual, starting treatment at the right time means an improved or normal life expectancy, reduced morbidity, not just from HIV-related conditions, but also non-HIV, and of course, reduced risk to partners. On a population level, you have the lower healthcare costs, the better productivity of a healthy population, and of course, reduced transmission on a population level, which in theory could help address the epidemic. Now, really, of course, and again, I'm sure you'll all be very familiar with the START trial. This was the randomised controlled trial which confirmed what some cohorts had suggested in terms of the benefits of early antiretroviral therapy. And people with a good CD4 count, not on treatment, were randomised to immediate or deferred ART. And what this shows, you can see quite clearly, a almost 60% reduction in the combined primary endpoint, and that was death, serious AIDS, or serious non-AIDS related events. 57% reduction in the immediate treatment group, and the study was stopped early on that basis. Now, if you look at the actual median CD4, although to enter the study you had to have a CD4 count above 500, the average CD4 at treatment initiation in the immediate arm was actually 651, but even in the deferred arm, it was actually still pretty high at 408. So here, I think, certainly by the British guideline standards at that point, that was very early treatment is significantly better than early treatment. Now, of course, there's much debate about the conditions that drove that, and this graph here on the left looks at the serious AIDS-related conditions, and you have the blue broken line for deferred and the red line for immediate initiation, and on the right are serious non-AIDS events. And you can see that quite surprisingly, perhaps given the CD4 counts in the study, there was a big difference in terms of AIDS-related conditions. But actually, although not so great a difference, it was a significant advantage in terms of non-AIDS conditions as well. And what this means, actually, for the first time, the guidelines are all very unanimous. This is a topic that's yielded a lot of debate over the years as different guidelines have evolved and some guidelines have stuck to lower CD4 counts. But now we really have consensus. It's phrased differently across them all. But I think, of course, the British guidelines say it most succinctly that all people living with HIV should start ART. I would say that, wouldn't I? So in terms of other studies, so of course, we've got the very broad AIDS and non-AIDS related endpoints and the mortality data. There are a number of sub-studies within START. So of course, one of the concerns is a longer exposure to antiretroviral therapy perhaps going to negatively impact some of these surrogate markers of comorbidity. Now there's a liver sub-study and there's annual fibroscans in the subgroup. That data is pending. Cardiovascular sub-study, no difference. Pulmonary lung sub-study, no difference. Neurocognitive sub-study, no difference. The only subgroup where the outcome was actually slightly worse for the immediate treatment group was bone mineral density, but we know that starting any antiretroviral therapy regimen for initial therapy is associated with a small reduction in bone mineral density, and we saw the same in SMART, the CD4 guided treatment interruption study. Actually, the only endpoint that was better in the treatment interruption arm was bone mineral density. And there's some more detail at IAS looking at subgroups within the START study. So are there individuals not on treatment who perhaps you could more safely offer deferred treatment to? And really the answer was pretty much any way you looked at it, by the primary endpoint, immediate treatment was better. But certainly the effect was attenuated or in some cases almost eliminated in some subgroups. So people who aged less than 50, CD4 more than 800, a CD4-CD8, ratio, not ration, of greater than 0.8, so a normal CD4-CD8 ratio, a Framingham cardiovascular risk of less than 1%, and particularly individuals with a viral load less than 3,000, that risk, that benefit was slightly attenuated, but overall it was definitely of benefit. So moving on to the other, so we know from an individual health perspective that prompt initiation of treatment is good, and of course the other huge area of benefit is the impact on transmission. Now again, many studies here, and you'll be familiar with these two, I'm sure, that I'm going to focus on very briefly. HPTN 052 was the landmark first randomized controlled trial looking at the impact of treatment initiation on transmission in people in serodifferent relationships. As I'm sure you know, the initial analysis showed a 96% reduction in transmission where the positive person was on treatment, and the final analysis showed a 93% reduction in transmission. Now the key thing, and the reason it's 93, not 100%, there were 8 transmissions in the arm where the positive person was on treatment. So they did transmit to their negative partner, but in all of those the viral load was detectable. 4, because the viral load was on the way down, and as Anton already mentioned, with the studies using PrEP as a bridge, we know that when the viral load's coming down, there of course is no protection against transmission, and 4 actually virological failures. So antiretroviral therapy in the context of suppression, there were no transmissions. PARTNER is a large observational study, and certainly in the initial presentation, it was presented in 2014 at CROI. This is an observational study, again, it's looking at sero-different couples where the positive person is on treatment and undetectable, and the negative person is being followed up regularly with HIV testing, regular STI screening, and questionnaires. Now, in the initial analysis, they reported 16,400 condomless sex acts in men who have sex with men and 28,000 condomless sex acts in heterosexuals, and there were no transmissions. Now, based on what we know about transmission risk and based on the number of sex acts, it would have been anticipated that there should have been 86 transmissions had the positive person not been on treatment. And these are the final results. They were presented at IAS this year and also published in JAMA at pretty much the same time. And now the cohort includes 888 serodifferent couples, 340 men who have sex with men. Now, the couples in the study had actually been having condomless sexual intercourse for an average of 2 years prior to study entry. I'm going to come back to that. But during the study, there was an eye-watering 58,123 reported condomless sex acts. And actually, and Anton talked about compartmentalization and vaginal rings not protecting against transmission through anal sex. Actually, 20% of the reported anal sex in the study was in heterosexuals. But there were no transmissions from primary partners. There were 11 transmissions, so 11 people who were negative at study entry did acquire HIV, but when you look at the virus, that was not from the primary partner. Now, there are some caveats around confidence intervals. The confidence intervals for men who have sex with men in the initial presentation were relatively wide. They are less wide now that there are more people under follow-up, and the longer those people remain under follow-up, then the tighter they will get. But the author conclusion was, we can fairly safely say that the chance of transmission from a virally suppressed HIV-positive person during heterosexual sex is negligible. However, we need to collect more data on gay men before saying this with the same degree of certainty, which I think is a very British way of saying things. Now, there are some caveats, and actually I think it's really worth reading the accompanying editorial in JAMA that was published alongside the final results of PARTNER. And these were the points they made, that people in stable relationships may not reflect all people living with HIV. And actually we've got some data from PrEP. So if you look at the rate of HIV acquisition in the PrEP trials, it was lower in Partners PrEP than it was in Voice and TDF2. And the difference there is in Partners PrEP, the people taking PrEP knew their partner was HIV positive. Voice and TDF2, the entry criteria were just to be high risk. You didn't necessarily have a positive partner. So certainly if you look at the PrEP studies, there's a suggestion there that if you know your partner's positive, you may immediately be at a lower risk because you may adjust your behaviour. So is it possible that the partner population was a lower risk population? The HIV positive people in the partner study had been on treatment for an average of 7.5 years. Very high rates of adherence. There were also high levels of sexual health screening and advice. So they were getting quite intensive advice about sexual health and sex practices. And actually, bearing in mind that people had been having condomless sex for 2 years before they came into the study, these were HIV negative people who were still HIV negative after 2 years of condomless sex. So is it possible that there's something about those individuals in terms of their HIV susceptibility that makes them lower risk? Now, you can talk about this, and we maybe could probably say that the risk is low and possibly this, but it remains that after more than 58,000 condomless sex acts, there were no transmissions. So I personally think we should focus on that, perhaps, rather than hypotheses about things that actually haven't happened. Now, in terms of how are you going to maximise the impact of treatment, so we know from HPTN 052, we know from PARTNER, we know from numerous other observational studies that an individual who is on treatment is not going to transmit to their partner as long as they have a consistently suppressed viral load. And so if you test people and get them on treatment straight away, they're not only going to enjoy the medical benefits for themselves, they're also going to have a more rapid impact in terms of transmission risk. And there are many examples of great success, and in the interest of time I've not included them, but examples of projects and clinics where a test and treat strategy has been very successful. But I just wanted to show you this one. Again, this was from IAS this year, ANRS 12249. And this is the first major RCT of a test and treat approach. So it's performed in KwaZulu-Natal, where there's a very high background prevalence of HIV, and it's a cluster randomised controlled trial. So each cluster was a geographical area of about 1,000 people, and there were 11 clusters randomised to the intervention and 11 clusters to the control. And the intervention was, they went out into the community and tested people for HIV every 6 months. But it's what happened if you were diagnosed positive that varied. So if you were in the intervention cluster, you were offered immediate ART. And if you're in the control cluster, you were offered clinic follow-up, but to start ART only in accordance with national guidelines, i.e. deferred. And what they showed, there's more than 28,000 people in the population, 1 in 3 were already HIV positive, 88% of them tested at least once. But if you were diagnosed positive, whether you were in the immediate treatment group or the standard of care group, retention in clinic was really poor. Less than 1 in 3 had been to the clinic within 3 months, and only half by a year. And whichever arm people were in, that retention was still low. So if you put their goal was to sort of see if this intervention would mean that the intervention group, immediate ART, would hit those UNAIDS 90 targets. You can see actually there's the 90 targets at the top, but you've got green for the control group, standard of care, yellow for the intervention group, immediate ART, and you can see there is absolutely zero difference between the two. So even in this RCT where people offered immediate treatment, Here, there was no impact on the proportion of people accessing treatment by the end of the year. So here, it just didn't seem to work. And actually, when you looked at the rate of new HIV infections, that was the primary point of the study, would test and treat reduce the HIV incidence within those randomised clusters? And actually, the rate of new HIV was identical in the two. So there was no impact, as you would expect, because no more people accessed treatment. So in terms of that primary endpoint, it failed. And there's lots of analyses planned looking at why did people not engage in care? Why did they not go to the clinic? Was the intervention sufficient? Was it to do with community attitudes and stigma? There's lots of questions about why. But certainly, although test and treat can work, this is an example of an RCT where it didn't. So to conclude, what we know is people who are diagnosed in care and on treatment do very well. And as Anton and I have summarised, I think our challenges really are to improve diagnosis and to improve our access to prevention. And again, as Anton's already said, treatment as prevention will reduce, but it won't eliminate HIV transmission as long as people remain undiagnosed. Because, of course, treatment as prevention will only work in people who are on treatment, therefore diagnosed. And because of that, there's variable data about the population impact of treatment as prevention. We've seen many studies, some of which show a correlation of antiretroviral rollout or population viral load and the impact on the rate of HIV infection. Others don't. And certainly, as we've seen in the UK, well, we've got really quite good access to treatment, good retention in care, and really good suppression rates, particularly in MSM. We've still got rising rates of infection in MSM. So certainly for us, treatment as prevention is not working in gay men. And this is a study which shows it in the UK, and I suspect it will be almost identical in many other European countries, that in men who have sex with men, more than 80% of new HIV comes from undiagnosed people. So treatment as prevention straight away cannot impact that 80% of infections. And of course, the other major reason, of course, if treatment as prevention was going to work, and there's some suggestion that in countries where the epidemic is a more heterosexual epidemic, that compared to an MSM epidemic, treatment as prevention may have more an effect because less of the HIV comes from acute or undiagnosed HIV. But if it was to work, and if 90-90-90 was to be effective, of course, we're very, very far off achieving 90-90-90. So first of all, we have the inherent limitations of TASP, but also we have the fact that we couldn't even realise the full potential of TASP when we don't have enough people on treatment. And it can work, and this is some data from a couple of years ago, but suggesting that certainly in San Francisco, where they've got a combined approach, where they've been doing test and treat, and they've got a really good PrEP access program, and really importantly, a really good PrEP education program. Again, to emphasise, it's about people knowing about PrEP and knowing they can access it. But they've seen a dramatic reduction in new HIV infections in San Francisco, and certainly within that PrEP service, they've seen no HIV infections. So I think to summarise, PrEP works, treatment works, but unless you combine those two together and with all the other prevention and management strategies that we have, we're not going to be successful, and you have to combine to see success. Thank you very much.